name is Michelle Mabry, and I'm a clinical supervisor with Nutritious Lifestyles. I have the pleasure of introducing our speaker today, Janet McKee. Janet is the president and owner of Nutritious Lifestyles, a group of 180 dietitians, dietetic technicians, CDMs, and chefs that provides nutrition and food service consultations nationally. She specializes in adult and geriatric nutrition, nutrition for renal disease and pressure ulcers, and speaks nationally on nutrition for the healthcare and food industries. Janet is board certified specialist in geriatric nutrition, as well as a diplomat with the American Professional Wound Care Association. Janet will be sharing with us information on identifying, treating, and documenting malnutrition. At the end of this presentation, you will have a better understanding of how to provide excellent care for our residents and understand that there are certain types of malnutrition that are very difficult to treat due to both chronic and acute inflammation. So without further ado, I'm going to turn the stage over to Janet.
So, when I first got out of school, we really thought about malnutrition, and we just were so ingrained in us it was really about the weight. So, but it's not just about the weight. We now know that nutrition is very much affects every organ of the body. We now know so much more than we did even 20 years ago. It's not just about the weight. For example, edema can mask weight loss. Edema is actually a sign and symptom of malnutrition. Currently, the Academy and ASPEN have a consensus statement. There are 6 characteristics that suggest nutritional declines and malnutrition. We will be discussing each one of them. We'll also be discussing where you might look for that in your remote charting, and also what you might look at when we actually do go back in the nursing homes. As you're aware, many of us are not going into our facilities right now due to trying to keep our residents safe from bringing COVID from the outside in. Number 1 is insufficient energy intake. What does that mean? It doesn't mean the same thing for everyone, because a person that weighs 300 pounds, if he ate 100% of a 2,400 calorie diet, that would be insufficient energy intake. But typically, that's not who we see in nursing facilities. We're looking at people that are leaving a lot of food on their plate, such as 75%, 50%, and 0%. And where you would get that data from is looking at your ADL sheets and your PO records. Fortunately, they generally have those logged in, so if you're using EMR charting only, you can access that information. So that is one of the 6 signs and symptoms of malnutrition. Significant weight loss is another. So we all know that significant weight loss is a very important thing in long-term care, but it's also important in every aspect of care. Significant weight loss that's unplanned is not a positive thing. So going back and knowing what that means, it's 5% in 30 days, 7.5% in 90 days, and it is 10% in 6 months. But do we only care about significant weight loss? Of course not. Your job as a dietitian investigating weight losses is key. A person that weighs 100 pounds that loses a pound a month for even a 6-month period that doesn't have a 10% is still losing lean body mass. As we go through this seminar, we're going to have an understanding of how that insidious weight loss and inflammation and unplanned weight loss affect muscle density and muscle strength. So it's a pertinent, and I know we can't do it right now because some of you are not working in the facility, but we have to read the chart to do the best we can to have an understanding of what our residents are physically entailed as far as nutritional status. So we should be looking and listening when we're in the facility, and we should be looking at key components of the medical record for those of you that are remote. So if you read the chart, you will find that different parts of the facility are doing different things now, such as physical therapy. I have seen several hospital and nursing home facilities that do handshakes. When you are able to go back in the building and visit, you should always shake the resident's hand. If they cannot shake your hand for a full 5 seconds and hold it tight, and there's a very limited grip strength, poor hand strength equals a high risk of inability to feed their cells. Additionally, we should be asking ourselves, if they can't hold your hand tightly and grip it to where you really feel it, can they really grasp it for the 45 minutes that might take a dependent feeder or a person that needs assistance? Can they feed themselves? And typically, independently, the answer is no. Have those concerns been addressed with occupational therapy and the staff, nursing staff? Is there a plan of care? So I have 2 hands here for you to look at. Slide A to the left is an elderly person's hand that has some wasting. So if you look in between her thumb and her finger, you can't see it very well on this slide, you could on the previous one, then you will find that they have a scallop, an inverted scallop area. It doesn't look like a healthy younger hand that's not malnourished, because the muscles are very stable and strong in this hand. So that's a way, so you should be looking at people's hands when you shake them. The Interossei muscle is the main muscle that allows us to feed ourselves. Unfortunately, that is one of the first muscles that decline with involuntary weight loss, whether it's insidious or significant, and lean body mass declines due to weight loss, inflammation, and this all causes reduced strength of the hand. Inflammation causes a loss of lean body mass throughout the entire body. Another example that will be easy when you can see the resident is temporal wasting. If you look at this gentleman's face, you'll see by his eye, it looks like an indented scallop. There's no fat padding there at all, and his face is sunken in. If you look at his chest, you can actually see his collarbone, which should have fat and lean body mass over it, but it doesn't really have any. So another way that you may look at it is quadricep wasting. Now that's really, really important. They are currently in some progressive rehab centers that have a super strong physical therapy department are doing quadricep and calf circumference timing. So that way they have the resident for week 1, and after 3 weeks of therapy, if the muscle density is declining, that most certainly indicates an indication for malnutrition. So inflammation increases a negative response. Interleukins, also various things that are appetite cytokinins that reduce our appetite become prevalent, and they also reduce lean body mass. This starts the cascade of malnutrition, weight loss and decline, and the feeling of anorexia, or you just don't want to eat. So as your quadriceps, if you lose, let's say that you are not feeling well, you lose a family member, or the person has to go in a skilled nursing facility and they lose 10% by the time we get them. Well, the quadriceps are going to be wasting, which causes them to have inflammation. They've been depressed. They might have multiple comorbidities that cause this inflammation, which causes them to have declining mobility. The result is weakness and continued reduction in appetite and continued inflammation. Therefore, it causes the cascade of malnutrition. So once that inflammation and poor intake ensues, and the weight loss ensues, then the reduction of lean body mass, it's difficult to control that, and that's where we need to be really assertive and aggressive with our nutritional care plans. So additional things that you should be looking for in the physical therapist notes are chair strength. So a new test of muscle strength is chair strength. Can they get up and down of a chair by themselves independently within 30 seconds 4 times? Many of them will not be able to. Can they walk 40 feet unassisted? Look at your ST notes. Dysphagia, it can be a sign of muscle weakness. As we age, our ability to swallow declines anyway. Unfortunately, if you lose weight, it declines even more. So your body is full of muscle. As you're inflamed, as you lose weight, as you become malnourished, that ability to swallow has a reduction. Calf and quadricep reduction in circumference. You should be reading your occupational therapy notes, your PT notes, your ST notes, and your physician's progress notes to determine that. You're certainly, generally speaking, not going to see this information in the nursing records. Here's a picture of a loss of fat. So I'm going to point out and look at the scapula area. You can actually see skin folds in this gentleman's neck. You can count his ribs. You can see the indentation of muscle, and you can see all kinds of loose skin on his arms. He clearly has had a loss of muscle and fat tissue. You can literally see the skin hanging on his bones. So to the left is a healthy individual with adequate muscle and fat density. To the right, you can see someone that you can literally see their bones, counting, and look at the loose skin. Now, when you physically see this in person, it almost looks like a loose blanket. The skin is so loose. Here's a better picture of the hand wasting. So when you go to your facilities, you can look at that. So if you look at the indentation between the thumb and the forefinger, you can clearly see that this person has significant muscle wasting. Clearly would have difficulty holding a spoon or a fork or cutting due to muscle weakness. So that's really, really important. When you look at your hands, you should not be able to see valleys between the fingers. And if you look at this lady's hand, it looks like valleys, and there's an extreme deep indentation between her forefinger and her thumb. Again, this is what a loss of muscle and fat look like, and this is really important. So when you hear our elderly residents in nursing homes complain of being cold, they are, because their fat mass is diminished and they simply do not have the insulation to keep their bodies warm. So if you see a frail elderly lady that was 5'6" and weighs 97 pounds, she probably is freezing, even with the sweater, because of the declining amount of fat mass. So excess skin, muscle emaciation, and loss of fat equals multiple symptoms of malnutrition. So we often think of malnutrition being in third world countries. It is alive and well in the skilled nursing home area and also in the acute care hospital and LTAC arenas in the United States. We just sometimes don't see it. We have lots and lots of obese, malnourished individuals that need our help. So where would you look if you're remote charting, as many of you are? Well, where would you look for a source? For your admission assessment, because a lot of times if they have dysphagia on a puree diet, they're going to check that as a nurse. Your progress notes, particularly if there are some really strong PAs that write very detailed progress notes and actually do a very strong physical examination. your occupational therapist, your notes, your physical therapist, and your speech and your intake records, and your MDS, your feeding sections, and Section K. So remember that by the 5th day, the preliminary MDS is supposed to be completed, and they would have the ability to code out G to determine if the person needed assistance with meals or not. Most people that need assistance with meals have some level of nutritional decline. So if you're an older dietitian like myself and you don't feel comfortable asking someone to take off their bed sheets, you can use the handshake method. You can look at temporal wasting. You can look at their forearms and their upper arm area and look for wasting. So you want to look at their back of their arm. You can, if there's no fat on the triceps tensor or the forearm, that certainly is very concerning. You can look at their face. It doesn't just have to be the temporal wasting. Their eyes are generally sunken in the buccal area. It looks like Jed Clampett's dog on the Beverly Hillbillies. Their jaws are all sunken, hanging out. Also looking at edema for wasting of the muscle tissue in the ankle area, pitting edema, and looking at a skin examination for loose skin. These are all issues that are easy to find when you can actually see the person. And again, many of them will be addressed in PT and OT notes. So when you're looking, another sign of edema, of malnutrition, is edema. So these are actually patients. So if you look at edema, this person has pitting for edema +4, because you can leave the indentation in and it stays for a long period of time. So looking at their feet. So that happens for a number of reasons. One of them is albumin is a balancing act and a protein that keeps our fluid in the right tissue logs, such as cellular and interstitial. However, when that number declines, your albumin is 3.5 and drops to 2, you're going to do what's called third spacing. So make sure you're looking at your nurse's notes, your progress notes, your mid-assessment, your check-ins with your physician, and your PT, ST, and OT notes. So edema is something that's very prevalent in the nursing home industry. There's a lot of different kinds of edema. There's dependent edema in your lower extremities. There's edema that's related to malnutrition. Edema is definitely a sign of malnutrition. So I put that mask in since it's very apropos, because so many of us are wearing these everywhere outside our homes now. So it's important to remember that laboratory analysis are not particularly indicative of protein malnutrition, but yet they can be very indicative of nutritional risk, of mortality risk, and inflammation. An elevated CRP level, C-reactive protein, is indicative of inflammation. And albumin that's reduced is also indicative of inflammation and increased mortality. A person that has a 2.0 to 2.5 albumin level has a 75% increased mortality rate in 6 months. Low albumin, high CRP level equal inflammation. There are many different ways to look and see if the patient has an inflammatory disease. You don't always have to have labs. If you don't have them, you can certainly work around them. So the Academy and ASPEN have determined that we actually have 3 types of malnutrition that dietitians categorize. So we have the type of malnutrition that is related to generally just a lack of food. And many of our residents, such as that have solely just dementia, they may certainly have just that diagnostic of a lack of food because they're refusing to eat. We have other people that have up to 5 to 10 chronic disease status. We have other people that have acute disease related malnutrition. This is particularly important with COVID. So how do we know what to do? Well, the Academy has kindly made an algorithm that has been published. So once we confirm there's a nutrition risk through intake, weight loss, lean body mass, we first must know, is inflammation present? It's a yes or a no. So by looking at the disease process, you can determine is yes, inflammation there. And you also can look at and see if they had a low albumin or an increased COP level. But if they have diabetes, pancreatic cancer, RA, sarcopenic obesity, diabetes, those are all considered chronic disease related issues. So you would go through and work the algorithm. So if one only is just solely not eating, then they have an opportunity to be categorized as starvation-related malnutrition. However, if you have inflammation related to diabetes, COPD, cardiovascular disease, PVD, and your intake is poor and you've lost weight, generally speaking, you're going to have chronic disease-related malnutrition. If you've had an acute bout of pancreatitis and or you have had something like COVID, you've lost a lot of weight and you're not eating, then you would be certainly considered to have acute related malnutrition. So chronic and disease status is wrapped in the nursing home. We have all kinds of people that have to have dialysis, that have chronic renal failure, that have mild or severe diabetes, PVD, hypertension, pulmonary disease, cardiac disease, pancreatitis, osteoarthritis, vascular disease states, organ failure, cancer, arthritis, sarcopenic obesity, brain injuries, strokes, infections, sepsis, burns, and congestive heart failure. These are all acute diseases. Depending on where you get the patient, it's either an acute stage or chronic stage. So the Academy has kindly worked with ASPEN, and they've taken the time to list the signs and symptoms of malnutrition: insufficient energy intake, weight loss, loss of fat, loss of muscle, generalized fluid accumulation, i.e. edema, and muscle strength is identified by hand strength. All of those factors, if you have two of those, will be classified. I would not get tied up so much in looking at percentages, especially with remote charting, because it's going to be hard to manage that, or particularly anything but significant or insidious weight loss. I don't think the percentages make that much difference, especially with the guidance that we're giving on how to write it in the chart. That you're certainly not going to say words like malnutrition. You're going to put things like so-and-so is at risk of malnutrition related to chronic disease state and poor intakes, history of weight loss, common. And that certainly is the way that we want to document this nutritional decline, because we certainly do not want to be involved and be accused as dietitians are diagnosing or be involved with ICD-10 codes, which I will be addressing. These are some signs, and Mariah gets the credit for putting this nice handout together. These are some of the signs and symptoms that we just discussed, talking about loose subcutaneous fat, looking at your facial areas, your triceps and biceps. If you can take someone's bicep and you can pick up skin and go up an inch, they have too much loose skin and generally they are malnourished and weak. Lower back, and also don't ever forget to look at the nurse's notes to see if a person's back has edema. If someone's gained weight and their ankles are skinny, they might be holding the fluid in their back because they're flat on their back most of the day. You're looking at temple wasting, neck, clavicle showing, shoulders showing, intercosseous muscle, edema. You're looking at all those factors. Many times we in the nursing home industry do not have time to do all this examination, but we can certainly look at someone's face, someone's scapula, somebody's hand, somebody's arm, and we can get an idea. And after you've done this multiple times, you just kind of feel it when you walk in the room. Unfortunately for us, as time has went on, I have noted that we have so many people with so many comorbidities in the nursing home industry, and they truly do not respond optimally if they have chronic disease statuses, such as diabetes, such as CHF, etc., until the inflammation is resolved. And sometimes the inflammation cannot be resolved. So inflammation plays havoc on the body. It reduces the immune response. It causes acute phase reactants, which would be fibrogen, CRP, ferritin, albumin. It causes all kinds of screw-ups with your labs. It causes interleukins. It causes to have a reduction in the ability to mobilize nutrients, and it decreases lean body mass. And the one thing I can tell you that when I studied for my geriatric boards, which has been twice now, everything I read was you don't use it, you lose it. Lean body mass and the retention of that is linked to healthy aging. So acute phase reactants that go up with inflammation would be ferritin and C-reactive protein. Those that go down would be transferrin, retinol binding protein, and albumin. So again, these are inflammation and mortality markers. A low albumin does not mean that you're generally protein deficient. What it does mean is you most certainly need investigation, because most likely the patient is at nutritional risk and may be malnourished. So again, inflammation, and it's been described by some of the seminars I went to, that inflammation is like a slow burning pot-belly stove. Instead of functioning optimally to provide nutrition to our tissues, unfortunately what happens is our body inflammation puts all this energy into trying to stay alive. The impact is negative. Reduction of appetite, reduction and loses lean body mass, which lean body mass weighs more than fat. All forms of malnutrition are treated similar, but the outcomes may not be optimal if the person is in an inflammatory state. So we are expected as dietitians to be the nutrition expert and to do complete assessments. We're looking at food intake, weight status, body mass index, weight history, signs and symptoms of inflammation, diagnostics, signs and symptoms from the previous dietitian or whoever your dietary manager are, in the facility, your physician, your DO, your nursing, and your rehab department. You're looking at the skin, you're looking at physical status, and you're looking at functionality, which is really new for us. Physical status and functionality go together. It's important to realize that many people, as they become malnourished, they simply cannot feed themselves. They lose the will and ability to eat. It should help these individuals. So I beseech you to please look at the charts and make sure that if there's a referral to ST or OT, it gets done, and we very much communicate with our nursing staff that we have concerns about this person being able to feed themselves. We're looking at social, medical, and diet histories. So here's case study 1. We have Mrs. Jones that has diagnostics of diabetes. She's on dialysis. She has chronic renal failure for the last 8 years, finally had to go on dialysis last year. She's only eating 25%, has a weak hand grip. She has plus pitting edema in her lower extremities, and she's lost about 18 pounds, which is greater than 10% in the last 90 days. Does Mrs. Jones meet the criteria for some form of malnutrition per the Academy? If so, what does that look like? Is Mrs. Jones at nutritional risk? The answer is yes. The documentation you would be expected to document would be something to the effect of Mrs. Jones' nutrient needs are 1,800 calories and 80 grams of protein a day. Her current intake of a no added salt consistent carbohydrate diet with no bananas or citrus, that diet only meets 31% of her caloric needs and 20% of her protein, particularly since she's on dialysis. She has diagnostics of chronic renal failure, diabetes, plus pitting edema, and a reduced hand strength per OT or PT. What's the plan? We're going to address the following. Mrs. Jones' significant weight loss, chronic disease status, and poor intake suggest that Mrs. Jones has compromised nutritional status, and she is at risk for chronic disease-related malnutrition. So, and if you need to tie that back, you certainly can due to disease status and poor intakes and weight loss. We're going to add a high-protein snack based on her preferences of a turkey sandwich, which is a very small amount because we don't want to overwhelm them. And then in the evening time, we're going to give her whole milk and a cookie, and we're going to not worry so much about her blood sugar because we're wanting to get her to eat. Our plan further goes that we're going to address dry weights with dialysis. Remember that the dialysis centers are supposed to send a report card. We can also reach out and make sure that the nursing staff is getting those dry weights. We're going to look at the labs that are pulled from dialysis in our facility. We're going to collaborate with the hemodialysis dietitian, the care plan team, and the physician. Now, it's important that we document this per the care plan. Now, some of you in Texas may not write care plans, but a lot of us do in Florida and Ohio. So the care plan would be the resident is at nutritional risk due to poor intakes, diabetes mellitus, chronic renal failure, and significant weight loss. So there's poor intakes, chronic disease, weight loss. Those are your two. Poor intakes, chronic weight loss. Our goal is to try to consume 75% of the diet and to maintain a weight of 150 pounds plus or minus 10%. So an approach would be provide diet and snacks for one, monitor weights and intakes, and refer to OT because she has a reduced hand strength and possibly would not be able to feed herself. Mrs. Fusion is an 89-year-old female for case study 2 with a diagnostic of Alzheimer's, dementia, and depression, anxiety, sarcopenia, and severe muscle wasting and weakness. Mrs. Fusion clamps her teeth down and refuses to eat her regular diet. She has a full set of teeth and snacks. Her average intake is only 35%, and she has a significant weight loss of 30 pounds over the last 6-month period. Her preferences have been obtained. She gets a select menu, yet she continues to refuse her diet. Her husband recently died, and she clearly states, "I am ready to die." Is Mrs. Fusion at risk for malnutrition? If so, what type? If you look at this, chronic disease, acute or starvation-related malnutrition, which one is at hand? Both these clients are malnourished. It's starvation related. So she's going to have these signs and symptoms of malnutrition, muscle wasting, etc. So how would we document that? Mrs. Fusion's intake of 35% does not meet her nutrient needs of 1,500 calories and 65 grams of protein daily. Due to her severe and significant weight loss history during just the last 6 months and poor intake of foods, Mrs. Fusion is at risk for malnutrition related to purely inadequate food intakes. She is clearly making the choice, now she may be demented, to avoid eating, and she has that right. We're going to try to entice her of getting more food in her by giving her chocolate pudding, cheesecake at HS, and a whole milk. We're offering a fortified soup at lunch. We're not sure if she'll eat it or not, but we're going to try. At one meal, we're going to continue to monitor her weight, intakes, fortified food, and snacks. We're going to send this back to the physician to communicate to he or she social services and care plan regarding the risk of malnutrition due to poor food intakes and refusals. Mrs. Fusion may continue to experience unavoidable nutritional declines and continued weight loss if she continues to refuse her meals, and she has that right. Mrs. Fusion is at risk for malnutrition related to her inadequate intake and meal refusals. The facility is providing her over 3,000 calories a day and 120 grams of protein, which greatly exceeds this individual's needs. So a sample care plan would be Mrs. Fusion is at nutritional risk due to poor meal intakes, her dementia, and her meal refusals. The goal is to try to get her to consume 50% to 70% of her fortified food, meal, and snacks. So we're going to provide her diet, her snacks, honor her preferences, monitor her PO, her intakes, and refer her to the physician of social services. It may be that the team gets together and decides that she's to be offered hospice because she truly does want to die. And she has the right, and her family has the right, if they're available, to discuss those opportunities to change her care plan. Appropriately document nutrition risks regarding acute and chronic disease and inadequate intakes. Close the gap. Again, I have reviewed many charts as a dietitian and an expert. It's essential that if somebody loses weight, we equate their needs, we estimate them, we average their intake, and we close that gap. So this person has a 1,200 calorie gap. We got to do something about that. Now, there are a lot of different ways. There's snacks. There's also giving whole milk. There's always a different way to skin a cat, so to speak. But we must address in a care plan closing that gap. Can acute disease-related malnutrition occur in long-term care? It absolutely can, and as a matter of fact, it's occurring right now. So this is a case study of a patient that has COVID. Mrs. Boutinas is a 98-year-old female admitted as a COVID-19 patient with respiration and disturbances. She has the type of COVID that affects her upper respiratory tract. She's lost some weight. She's had a 10% weight loss. She has a diagnosis from the hospital of dehydration and dementia. Her intake of 50% does not meet her nutrient needs of 1,600 calories and 75 grams of protein. Her current weight of 158 pounds is 60 inches tall. We will continue to provide her food lights, give her her select menu, offer her fortified soup or potatoes every other day. So potatoes one day, fortified soup the next. We're going to try to get her to accept whole milk on her trays. We are providing an enormous amount of calories. Due to the recent COVID, the reduction, remember, COVID in the upper extremities reduces your olfactory sensitivity. So we taste about 80 to 90% through our nose. Respiratory issues and weight loss and poor intakes and taste disorders, she clearly meets malnutrition, most likely related to chronic disease. So when we identify someone's at nutritional risk, in all cases, we want to refer that to the NDS coordinator or DON, because as you're aware, there is an increased reimbursement for malnutrition on the current NDS. So our problem is she's at nutritional risk because of recent severe COVID episode she had, poor intakes, weight loss. We would like her going forward to consume 75% of her meals. She may not be able to do that in fortified foods, might hopefully get up to 50, then go up. Provide her diet, her snacks, fortified foods, monitor her weight, refer to the MDS coordinator, care plan team members, and the physicians. So what is our role in all of this? Do we have a role? Absolutely. Do we have the same role as a physician? No, not at all. Our role is to use PAS statements in terminology that's comfortable and within our scope of service. For example, inadequate energy intakes related to diabetes, hypertension, renal disease, poor intakes. So we need to make sure inadequate energy is within our scope. So we are not allowed to utilize ICD-9 codes. These are for physicians. These are billing codes in acute care and long-term care. You will see that the NDS picks up, I think it's, the 44 series, 43, 44, can go in the NDS now as a coding to increase reimbursement for services they clearly would need. But these are physicians' roles. We have a lot more to choose from back in ICD 5, 4, etc. We only had a couple, marasmus and kwashiorkor and a mix. Look at all the different now that we have now of diagnostic codes that can be used for the physicians. Now in the hospital, the way that it's been working, because there's a huge reimbursement if it increases their caseload mix, the dietitians are saying that patient is at risk for malnutrition and referring that to the physician for diagnostic. We can use the patient is at risk of malnutrition related to poor intakes, weight loss, and chronic disease status and refer that to the physician. It's important that we communicate when we determine that someone is at risk for malnutrition with our chief nursing officer for your behavioral facility, our director of nursing, and the physicians regarding the risk of malnutrition. The physician can work with MDS and add the diagnostic. Now, it is important that these services, because the cost of taking care of a malnourished resident is much, much, much higher than taking care of a person that does not have malnutrition. There are increased opportunities for reimbursements for really needed clinical care. It can take an hour and a half to feed a person that's a dependent diner to assist them with meals that has dementia and dysphagia. So those services, it helps oversee some of the costs to provide those necessary services for our residents. So a sample of a care plan would be residents at risk for malnutrition due to poor intakes, weight loss, COPD, etc. And actually, this isn't a care plan, it's just a referral to MDS, DON, and MDDO. So it's important that dietitians treat malnutrition the same, whether it's chronic, acute, or just poor intake related. We follow up, we monitor, and we revise the plan of care. Responses will differ. If someone has end-stage cancer or they have acute pancreatitis, they are not going to respond to a simple calorie deficit as someone that was depressed. They had COVID, and once they get through that depression and COVID, their appetite perks up, their inflammation is gone, they start eating again. That's very treatable. Always, always document unavoidable clinical outcomes, such as weight loss and declining nutritional status. There are people that actually are offered and consuming more than their estimated needs, but because they are in such a flux of inflammation, they cannot metabolize, absorb, and build lean body mass because their body is producing those negative acute phase reactants. So an example would be Mrs. Odify is eating 85% of her meals and snacks. She has failure to thrive, COPD, coronary disease, and she's still losing weight. Currently, her intakes are exceeding her estimated needs. However, due to her disease process, she is not able to utilize her nutrition in an optimal way. Negative outcomes may be unavoidable, including weight loss and additional nutritional declines. That is an appropriate way to document that in the medical record. Now, document a lack of response. That's important too, because a lot of times we're offering these clients 3,400 calories a day, but the outcome is still not good. How do we document that? Mrs. Otify is receiving a regular diet with fortified soup. Now remember, your fortified soups have 450 to 600 calories. She gets a different fortified soup on the rotation schedule of 5 different in a rotation daily. Her intake is 75%. She's exceeding her needs of 1,200 calories. However, her wound just continues to get progression and progression. Her weight is declining. She's had a weight loss of 10% in 90 days. She has diagnostics of diabetes, elevated blood sugar, PBV, COPD, and her CRP level is 300% above normal. She also has pitting edema and a low albumin. There is a concern that Mrs. Otify may not be able to effectively utilize her nutritional intakes. We still, as clinicians, are obligated to treat that. We'll add high-calorie, high-protein puddings or dessert at dinner. Daily can continue to support the healing process and nutritional status. So we can try to do different things, but we still may have a negative outcome. As I'm stating, that further negative outcomes might be unavoidable, such as weight loss. So if you go back and you look, her body is fighting to survive. She's in a reduced metabolism rate, but her body is just not able to assimilate lean body mass, and she literally is wasting away, and she has failure to thrive. So unavoidable declines happen all the time while people are exceeding nutrient needs. Are you documenting that? Are you looking at that? So obesity is a huge factor in our society today. 1 out of every 3 Americans is obese. And in certain states such as Louisiana, Alabama, Texas, and Florida, more than 30% of our populace in and out of nursing homes experience obesity to the point that it interferes with their life. Don't let weights fool you. Many obese residents suffer from extreme nutritional declines and malnutrition such as sarcopenic obesity. So an obese resident, Mrs. McKee, is currently 325 pounds. Her mobility is really poor. She has extreme weakness in her quadriceps. She's not able to walk very far. She has third spacing and a weight loss of 17 pounds in the last 30 days. Her albumin is 1.3. She has a stage 3 pressure ulcer or pressure injury. Her intake is 50% of a consistent carbohydrate diet, no added salt with snacks. And her diagnosis of diabetes, she needs 3,000 calories a day, 104 grams of protein, but she's only able to eat due to her illness and just not feeling well with 1,200 calories a day and 45 grams of protein. Her hand grip is not good. She can barely hold your hand. And she cannot walk by the hall, even with a PT assistant, more than 3 feet. Is this resident compromised? Yes. They have sarcopenic obesity and chronic disease-related malnutrition. So the facts: this patient has a history, a resident has poor intakes, weight loss, muscle weakness, and you can look at the obesity and it's difficult to tell if it's just fat or edema, but this particular patient had edema. They have a low albumin and they have lots of diseases or inflammation down. These are the facts. Now, if you look at this historically in the past, anybody that was overweight, as dietitians, I was trained in school, we should try to get them to lose weight. But you do not want to do that in today's current nutrition environment because it's just not healthy for the resident. We need to heal that wound first get them stabilized, and worry about the weight later. So the suggested treatment would be adding high-calorie, high-protein snacks, BID, monitoring skin and weight, and because the hand strength is so weak, perhaps they need adaptive equipment or they need to have a written plan of assistance at meals from nursing. Does the resident meet the criteria from ASPEN and the Academy for Malnutrition? Absolutely. Chronic disease-related malnutrition. Thank you for your time. And Michelle, are you back on? I guess her internet. Are you able to go over what they need to do for their CEUs and take questions?
Yes, absolutely.
So Michelle's back on. So if you have a question, please ask.
Yes, if you have any questions, just go ahead and type that into the chat box, or you can raise your hand and I can unmute you. While you all are thinking of questions, I'll send a reminder that if you called into the webinar today and did not attend via the computer, then send me an email at michelle.mabry@nutritiouslifestyles.com, and that way we can get you your CEUs sent out from the office. And additionally, after this, you'll receive a survey that we need you to please complete and send back. It'll come through SurveyMonkey, and that is to keep us in compliance with ANFP and CDR, and we also greatly appreciate your feedback. So I have a question here.
Pop up. Can you speak it loudly so I can hear it?
Yes. It says the nutrition diagnostic terminology list. Evident protein energy NI-5.1. I have used this in my PES statement. So you don't want it to be used anymore?
No, I didn't say that at all. It's fine to use that inadequate protein or energy intake related to the diagnosis. The only thing I'm saying is don't use the ICD-9 codes. Don't go back and use ICD-10 codes. Those are listed what you can't say in the PowerPoint. You don't want to say the patient is malnourished. You don't want to use, you just don't want to use that. You want to use it. And what I'm saying is at risk, you can use any PES statement that you would like to. But you can use that as a PES statement, but when you're concluding it, that's completely different. A PES statement is not a diagnostic. You can use whatever the Academy says in your PES statement. You're not going to conclude that by stating that you're diagnosing malnutrition. So you can use that as a PES statement. You cannot conclude the note because you don't want to have that. And you need to be very careful when you're using that so it's not misconstrued. You need to make sure your PES statement is very clear and not tied into have that you don't want a physician upset with you that you're diagnosing. So you can easily handle that.
Okay, we have
there's some more questions.
Yes. So it says, what if they already have the diagnosis of malnutrition already?
Feel free to use it. So if the patient has malnutrition and you check the face sheet and the ICD can make sure that you accurately record what they have. For example, if they are coded to have malnutrition not unspecified, in the code you can clearly put in your note that, and this is the treatment that you're going to recommend to treat that diagnostic. There was another question too, but I couldn't catch it fast enough.
Yes. It says, how should we address residents with poor PO intake not accepting our food first protocol? What is your judgment with supplements?
What my judgment with supplements is they should be used as a last alternative. If they're not accepting fortified foods, so you have to do something, but you should try to have the least amount of supplements possible, because if you do something like a shake TID, they can't eat it. So you want to do something that's practical. You want to start slow and build up if you have to. So for example, let's say that you have someone that's just not eating, and the only thing that they're interested in taking is a milkshake. Well, you can certainly add that if you've explored fortified foods and they're not willing to take that. But I think we're leaning against using a lot of supplements because we've seen such waste of that over the months, and it's better to use a smaller portion size, like a 4 or 6 ounce versus the 8 ounce serving. Also, you can use MedPass. But there's many different ways. If somebody's not liking fortified foods, really, you can also look at it. If they want to eat cake every meal, who really cares at 85 years old, just so we get some calories in that? So sometimes going back and saying, would you like to eat cake? And by the way, you can have it before you eat the rest of your meal, and that's fine, is a different strategy of how you might approach nutrition. I think we always think about, we got to get this and we got to get that in them. But let's just focus on making them happy. If they have chronic disease-related malnutrition, let's get them calories they'll eat, and let's focus on the positive versus worried about the amount of protein. There's other questions, but I'm not able to read them. So, Michelle, I'll have to get you to read them.
Absolutely. So Johnny Dean just responded and said that he has found that if MedPass 2.0 is available, he's seen quite promising results by using 60 cc's BID between meals for 30 to 60 days. And they typically improve in 2 weeks to a month.
Well, I have found that to be very helpful as well, so I appreciate him bringing that attention. What I have found not to be helpful, and I have been in many patients' rooms, and those that give Ensure, and it really doesn't matter that one of our clients has a very inexpensive Ensure GPO rate of 56 cents a can. It really doesn't matter because the cans are sitting up on the marble windowsill. So we need to understand what our residents will take, and MedPass is an excellent opportunity. Next question, please.
It's I have another statement here. It says, I learned in school that mild protein calorie nutrition isn't a DX, only moderate or severe malnutrition. I noticed it listed on the ICD list. Is mild malnutrition as a diagnosis that is used now?
Yes, those are the ICD-10 codes. They are fresh out. They're currently in use. Those change every so often. Since I've been practicing dietetics, this is really telling my age, but the other night I was watching one of the many reruns of Law and Order, and it said ICD-9 code, and it was talking about 4. And so that's really been a long time ago because Law and Order was on for 20 years. So every few years they flip off and upgrade to the next number. Any more questions?
That's all we have right now. Does anyone else have a question? Because now is an excellent time to find those answers.
So I would like, there's another one in here, but I can't read it either. It's from Lacey Riddens. Can you read that out, Michelle?
Yes. It said, had a psych Jerry patient, so I guess geriatric patient, who was admitting for fasting and refusing to eat or drink with 20-pound weight loss prior to admission due to his psychosis and belief that God was telling him to fast for 90 days. He continued to fast for a total of 37 days. He was mute for the most of his stay at my facility. He suffered an additional 20-pound weight loss in less than a month. Pre-albumin was low at 10. I documented every week on him and spoke with the medical director about need for IV hydration. The MD repeatedly said his labs aren't bad enough for ER docs to provide hydration. After day 37, the patient started to eat on his own and gained 40 pounds by the time he left. We monitored for refeeding syndrome. Should the patient have gotten IV hydration?
I don't think so, because the patient, if their labs were sustaining, he may have not been putting out any urine. It depends on the labs. But the dietitian should not just depend on the physician. They should have been looking for physical signs and symptoms of dehydration and reporting that, because I don't know how frequently they were doing the labs. The labs may not have been frequent and supporting that. So there could have been dry skin, dry mouth, etc. But if the patient was keeping their mouth shut, there's not a lot you can do about that. Now, I have seen, which I didn't necessarily agree with, but we have had patients before that we have done a temporary NG tube and provided that in a nursing facility, not a psych facility, but that is one of the options that would be available in a nursing home besides shipping the patient out to an ER, especially now with COVID. Any other questions?
Someone was asking what resolved the fast at 37 days versus 90 days.
Hopefully their psychiatric medicine kicked in.
Right.
Any other questions?
The statement was he beat his previous record of 35 days and decided to end it. No, there are no other questions at this time.
Okay. And so if there's other things that, other speaking engagements that you feel would be very helpful, if you would please fill them in. And then there is another question. It's from
Yes.
Danny Blackwell, but it went away super quick and I couldn't read it.
It says, how do we approach residents requesting weight loss?
Well, I'll be happy to answer that. It's the resident's choice, particularly if they're obese. We should always do our evaluation and talk with the patient. And if they're asking for weight loss, we need to look at their clinical condition and provide them the pros and cons of their decision. Let's say that Mrs. Jones weighs 300 pounds and she has a diabetic wound on her thigh, vascular. She has a pressure ulcer stage 4 off her heel. Well, that might not be the best time for her to lose weight. So we need to educate her that she might compromise her healing ability. But if she says, yes, that's what I want, it is what it is. You would try to do the best you could to convince her to have a very mild reduction in caloric value, such as a regular diet with small desserts. My experience has been, and that needs to be care planned, it's her choice, because absolutely they have a choice to lose weight. My experience has been that if someone says they want to lose weight and they weigh anywhere from between 200 and 600 pounds, they say that, but then you go in their bathroom to wash your hands and they've got a pound bag of M&Ms hidden behind the toilet. So a lot of times we do get disordered eating patterns in long-term care, not just our behavioral. So in some facilities are getting people that are applying for Medicaid paid for gastric bypass surgery, and they do have to attempt to go on the diet. So you will be seeing more of that. Any other questions?
Not at this moment. Are there any final questions this evening?
So Michelle, can you go over, you already went over the CEUs. Is there anything else that you need to conclude with?
No, I just want to thank you so much for presenting to us this evening, Janet, and I apologize for my internet connectivity issues early on.
No problem. I appreciate you helping us out, and hopefully please send some cuts. Right now, because of COVID, I have a little bit more time on my hands, and I love to do these classes. So if you have something else that you're interested in, such as whatever the case may be, wound care, anything of that nature, we'd love to provide additional education. Let us know. Thank you so much.
Thank you, Janet. Thank you to everyone who attended this evening.